Hello, everyone. I am Leah Parker, and I'm here with Benjamin Jacobs, and we're both the clinical pharmacy residents here at OSU Medical Center. So today I have a presentation for you on community-acquired pneumonia, or CAP, specifically the 2019 update on diagnosis and management. So the CAP guidelines were recently updated in October 2019, having gone 12 years without changes. Therefore, we found it to be important to provide you with a brief summary of the updates and changes within the guideline recommendations, as we were all very much anticipating this update. For the overview, I'll first talk about some definitions, a little bit of microbiology background, diagnosis, and then treatment. The objectives for this presentation are: 1, to identify organisms associated with community-acquired pneumonia, or CAP; 2, develop a treatment regimen based on the severity of illness; and number 3, recall adverse drug reactions associated with the treatment of CAP. So within the updated guidelines, there's a very useful table provided that lists a very basic summary of the major edits or changes that were made to the guidelines. Essentially, it compares the previous recommendations versus the new guideline recommendations. So I simply wanted to point this out as it's a great reference table to utilize. And we'll go ahead and jump into the first section, which is definitions. So these are all the terms you guys are already very familiar with. As you know, definitions of pneumonia can be split into different categories based on the setting in which it was acquired. So community-acquired pneumonia, or CAP, is defined as an acute infection of pulmonary parenchyma acquired outside of healthcare settings, while on the other hand, nosocomial pneumonia is defined as pneumonia that is acquired within the hospital setting. And this can be further subdivided into hospital-acquired pneumonia, or HAP, which is pneumonia that's acquired at 48 hours after hospital admission, in addition to ventilator-acquired pneumonia, or VAP, which is pneumonia that is acquired at 48 hours after intubation. It's also important to revisit that the term HCAP, or healthcare-associated pneumonia, is no longer used and has been removed from the updated documents. The second section we'll go over very briefly is the microbiology. So we'll kind of refresh our memories on the common pathogens. So the pathogens involved in CAP can be divided into 3 different categories: typical bacterial pathogens, atypical bacterial pathogens, and then viral etiology as well. So starting with the typical bacterial pathogens, as shown here on the left column, the most common bacterial etiology is strep pneumo, followed by H. flu, and then Moraxella catarrhalis, and then other species that are listed below. CAP can also derive from some atypical bacterial species, such as Legionella, Mycoplasma, and Chlamydia species. And then finally, on the right, you can see that there are various viral pathogens that are identified very commonly in the etiology of CAP. On to diagnosis. So when talking diagnostics for CAP, there are 3 major parts involved in the discussion. When the guidelines discuss how to approach the diagnosis and management of CAP, they first mention the 2 major principles, meaning you must first make 2 specific determinations before proceeding. So number 1, defining the severity of the infection, and number 2, defining your patient's risk factors for MRSA or Pseudomonas specifically, which we'll discuss more in detail in the upcoming slides. The reasoning behind that is that these quote-unquote 2 major principles exist to guide appropriate treatment setting, inpatient versus outpatient, as well as treatment course. So do we want something more broad spectrum versus can we use something more narrow spectrum to approach management? So then that brings us to the 3rd piece of the puzzle, which is diagnostic testing in the form of cultures, labs, imaging, etc. So first, we'll take a little more detailed look at the 2 major principles, starting with the first one, which is defining risk factors for MRSA and Pseudomonas. So based on the research and literature mentioned within the guidelines, these are the strongest risk factors associated with MRSA or Pseudomonas CAP. So first, a patient having a prior history of MRSA or Pseudomonas. Second, a patient that is currently being empirically treated for either MRSA or Pseudomonas. And third, a recent hospitalization within the past 90 days and or recent history of parenteral or IV antibiotic use within the last 90 days. The guidelines also mention that clinicians should be aware of the epidemiologic risk factors for MRSA and Pseudomonas that are specifically related to our hospital, our outpatient facility, and our specific patient population. And this can be reflected in the use of our antibiograms. Next, we're going to take a little more detailed look at the second major principle, which is defining severity of illness. So as you already know, this basically translates to categorizing your patient into severe versus non-severe pneumonia. So how to determine this? Here on the right-hand side is a screenshot from the updated guidelines that outline how to determine if a patient meets criteria to be considered severe. In order to be considered severe, the patient must meet either one major criterion, which is at the bottom and consists of septic shock with the need of vasopressors or respiratory failure requiring mechanical ventilation, or they must meet 3 or more minor criteria, which are listed above that. So why is this important? This is important for not only your approach to treatment consideration, but also whether or not your patient should be treated outpatient versus inpatient, as we've stated before. So another layer that goes into defining severity is the use of validated clinical prediction rules, which most of us are familiar with. These quote unquote validated clinical prediction rules help to determine the best treatment setting for the patient based on their disposition. Are they able to be treated outpatient, or is hospital admission recommended? So of course, it's important to note that the guidelines recommend that clinicians use these validated clinical prediction rules along with appropriate clinical judgment. So some of these, to give specific examples, one measurement scale is CURB 65, which is probably what you're most familiar with. CURB 65 is relatively simple, stands for confusion, blood urea nitrogen elevation, respiratory rate, blood pressure, and age over 65 years old, with these parameters here. And then there's a second one also called Pneumonia Severity Index, or PSI. And on the other hand, it is much more cumbersome than CURB 65, and I'll show you the table for that on the next slide. PSI has been shown to be able to identify larger proportions of patients that are actually at a lower risk and can be safely treated as an outpatient, meaning there is potential for its use to decrease healthcare costs in terms of hospital admissions. For that reason, PSI is actually recommended over the use of CURB 65 within the new guidelines. Interestingly enough, that is within the text of the guidelines, but it is not included within that fun, fancy table that I showed you at the very beginning of this lecture that kind of outlines all of the changes with the guidelines. It is not in that table, but it is within the text. So this is a snapshot of the PSI scoring criteria. This is just from MD Calc. This is just being used as an example to show you how cumbersome and detailed the PSI scoring actually is. As you can see, there's a lot that goes into it. So this is just kind of for your reference. For the final component of diagnosis, we'll delve into some of the recommendations regarding diagnostic specifics. So labs, cultures, and imaging. So first we'll talk about respiratory gram stain culture. So obtaining pre-treatment cultures and gram stain. Available literature showed that in patients, especially those in the outpatient setting and those with non-severe pneumonia, pursuing a microbiologic diagnosis via culture or gram stain does not change outcomes. Thus, based on this, the panel for the CAP guidelines made the recommendation to pursue a sputum culture analysis only in patients with severe CAP or those at risk for MRSA or Pseudomonas who are empirically being treated for these organisms. So as we discussed before, those that are at risk for MRSA or Pseudomonas are those with previous infections with those pathogens, or previous hospitalization or IV antibiotic use within the last 90 days. The guideline also includes the recommendation that those with severe CAP requiring intubation should undergo lower respiratory tract suctioning for sputum culture as soon as possible after intubation. For blood cultures specifically, recommendations are actually quite similar. The guidelines state that blood cultures are not routinely recommended specifically for outpatient treatment, but for inpatient treatment for non-severe CAP. But of course, clinical judgment can be used. They do recommend obtaining if you're empirically treating with pseudomonal or MRSA agents. The reasoning behind that is that the yield of obtaining a positive blood culture in those specific situations is relatively low. For urinary antigens, in terms of obtaining these, again, the recommendations are to pursue them only in severe CAP or in those with either a recent history of travel or if there's like suspected exposure to the source Legionella, and of course in scenarios whenever there's Legionella outbreaks as well. Influenza, for flu testing, the guidelines recommend to obtain one during periods of high activity of influenza. And finally, procalcitonin. The recommendation for obtaining procal levels are a rather gray area throughout the document. However, the official statement within the guidelines is that procal should not be used to determine the need to initiate therapy. This is still being researched, but procalcitonin's role is more suited to serving as a potential method for stewardship purposes and de-escalation in terms of one, helping to determine a patient's clinical improvement, and then perhaps number two, how long you'd like to continue antibiotic therapy, meaning would it provide a means to determine a shorter duration of treatment. So this is done less with a single level of procalcitonin and more with serial levels that show a trend. There's currently a study here at OSU being done specifically about procalcitonin and its use here, and that data will be released at some point and shared with you all. Next, we're going to talk about treatment, avenues for treatment, and we'll start with outpatient setting first. And so at this point, I will hand it over to my partner, Benjamin Jacobs, who will walk you through this process.
Hi, so this diagram here is a screenshot there from our current CAP guidelines, and I'll go into a little more detail about this here on this next slide. The treatment. So for outpatient treatment, we need to look at comorbidities versus patients with or without comorbidities. So if a patient has no comorbidities, which no comorbidities includes no risk factors for Pseudomonas. So in that case, we can use a single agent. So patients have chronic heart, lung, liver, renal disease, diabetes, alcoholism, malignancy, or asplenia, then we do need to treat with comorbidities and add that second agent. So once concern with a macrolide monotherapy is there's a high resistance rate to strep pneumo in our area, so we don't want to use it as monotherapy. If a patient does have comorbidities, the treatment changes to one or two agents. So this can be treated with augmentin, cefpodoxime, cefuroxime in combination with a macrolide or doxycycline. Or we can use a respiratory fluoroquinolone as monotherapy. These include levofloxacin, moxifloxacin, or gemifloxacin. So ciprofloxacin is not on that list as it does not have great coverage for strep. Next, treatment in the inpatient setting. So this is another diagram that has been taken out of the guidelines for non-severe inpatient treatment. So this can be treated similar to outpatient with comorbidities. So unlike outpatient treatment, we'll use IV antibiotics. So you can use a beta-lactam such as Unison, ceftriaxone, cefotaxime, or ceftaroline in combination with a macrolide. So Unison is going to be like IV augmentin. So Unison and ceftriaxone are the most commonly seen here. You could also do monotherapy with a respiratory fluoroquinolone. With inpatient treatment, it is important to get a history of patients' past infections, because if they do have a history of MRSA or Pseudomonas, we'll want to empirically treat for those organisms. For MRSA, we can use vancomycin or linezolid. We cannot use daptomycin as it's broken down by lung surfactant. For Pseudomonas, we can use Zosyn, cefepime, ceftazidime, imipenem, which only comes in combination with cilastatin. So imipenem we have to be careful with, as it's the most likely to cause seizures of the beta-lactams. So if a patient has a history of seizures, it may not be a good option. Meropenem or aztreonam are other options. Aztreonam can be used if a patient has a true penicillin anaphylactic reaction. And the final category we need to look at is recent hospitalization and parenteral antibiotics and locally validated risk factors for pathogens. For MRSA, we will withhold MRSA coverage unless culture results are positive in non-severe inpatients. If the MRSA NAIRS is negative, MRSA coverage can be held. If the nasal test is positive for MRSA, that coverage can be added. Cultures should be obtained for this population. Only add pseudomonal coverage if there is a positive culture, so it doesn't have to be empirically added. And then antibiotics can be de-escalated once sensitivities return. Now we'll move on to severe inpatient treatment. So this has some similarities to non-severe treatment. For patients with no comorbidities or risk factors for MRSA or Pseudomonas, it's recommended to use a beta-lactam with a macrolide, such as with non-severe treatment. This does differ since we do not use a fluoroquinolone alone. They must be in combination with a beta-lactam. If the patient has a history of MRSA or Pseudomonas, we need to empirically cover for those until culture results return. And also for severe treatment, the patient has recent hospitalization and parenteral antibiotics and locally validated risk factors for the pathogen, we do empirically cover for MRSA and Pseudomonas. And we'll also obtain cultures and de-escalate as appropriate. Now, when treating, our treatment duration will be guided by the resolution of vital sign abnormalities, such as heart rate, respiratory rate, blood pressure, oxygen saturation, and temperature. Patient's ability to eat, normalization of mentation, and achievement of stability must also be improving. Treatment should be done for no less than 5 days. That duration can be extended longer if the patient still shows signs of infection. Studies have shown efficacy in regimens of 5 to 7 days compared to longer durations. And studies have also shown an increased mortality and worse clinical outcomes if stability is not achieved by 5 days. If continued infection, the pathogen may be resistant to treatment, or there's an alternative source of infection. When treating, we also have some additional considerations other than just antibiotics, such as with suspected aspiration pneumonia. So one thing about the new guidelines teaches us that anaerobes may not play as big of a role in aspiration pneumonia as we once thought. Guideline recommendation to not routinely add anaerobic coverage unless lung abscess or empyema is suspected. When translated into clinical practice, it should result in less unnecessary use of clindamycin or beta-lactam / beta-lactamase inhibitors, and as a result of that, it could lower the risk of C. diff for patients. For pneumonia, we can also use corticosteroids, but that's not recommended unless the patient has severe CAP or refractory septic shock. And this is because no mortality benefit has been seen. There's also no effect on hospital length of stay or organ failure. So for a quick drug review, this is going to be over the drugs mentioned in the guidelines. So I won't include every antibiotic in the class, just the ones that are specifically mentioned. So penicillins, they're beta-lactam antibiotics. They will inhibit bacterial cell wall synthesis by binding to penicillin binding proteins on the cell wall. These are bactericidal antibiotics. So those in the guidelines include amoxicillin, ampicillin and sulbactam, augmentin, and piperacillin tazobactam. So when using these, some side effects you may see include GI upset, and that's going to be most common with augmentin. You can see a rash, acute interstitial nephritis, especially in combination with other nephrotoxic drugs, or drug fever. So there can also be an increased risk of nephrotoxicity with vancomycin. So that's one thing we need to look out for when patients are on both medications here. Are cephalosporins. So these are the next class of beta-lactams. They have the same mechanism of action as penicillins. They have similar side effect profile as well, including GI upset, rash, acute interstitial nephritis. The risk of this is lower when using vancomycin compared to when using vancomycin. Bone marrow suppression can occur with prolonged use. Seizures with accumulation that can be seen in all beta-lactams. A drug fever and biliary sludging in neonates with ceftriaxone. So you don't want to use ceftriaxone in neonates. The carbapenems. So these also bind to the penicillin binding protein. Meropenem and imipenem are the two mentioned in the guidelines. Now, ertapenem is not on this list as it does not cover Pseudomonas like the other carbapenems do. There's a similar side effect profile to cephalosporins with these, and seizures are the most common with imipenem, so use caution in patients with a history of seizures. The final beta-lactam is aztreonam. So it's a monobactam antibiotic. This is nice because if you use it in patients with an anaphylactic reaction to penicillin, they will not have that same interaction. So with this medicine, you can see increased serum transaminases, neutropenia, rash, and GI upset. Next class we'll talk about is macrolides. So these inhibit the 50S bacterial ribosome, preventing bacterial translocation. Azithromycin and clarithromycin are recommended options. Azithromycin has fewer drug interactions compared to clarithromycin, as it only has weak 3A4 inhibition, unlike the other macrolides. So you can also see QT prolongation with macrolides leading to arrhythmias, or you can also see GI upset. So tetracyclines, so doxycycline is the one mentioned in the guidelines, and it will inhibit the 30S ribosomal subunit. Doxycycline does not cause QT prolongation like azithromycin does. So if a patient has a history of arrhythmias or prolonged QT, this may be a better option for atypical coverage. Tooth discoloration can be seen in children under 8 years of age, so it's not recommended in that age group. Patients can also burn easier in the sun, have GI upset. So that can cause nausea and vomiting, so it's recommended to take it with food to help prevent that. Dress reactions can be seen. When taking doxycycline, esophageal ulceration can occur. So to combat that, patients should sit upright for 30 minutes after taking the medicine. The next class of antibiotics is going to be fluoroquinolones. These inhibit DNA gyrase and topoisomerase. Our respiratory fluoroquinolones are going to be levofloxacin, gemifloxacin, and moxifloxacin. Fluoroquinolones, we do need to use them with caution as there is growing resistance to the medications. And that's worrisome as these are the only oral antibiotics that cover Pseudomonas. When taking this medication, patients should be counseled to cut back on physical activity during use since these can cause tendon rupture. CNS effects and sun sensitivity can be seen with these as well, such as peripheral neuropathy. QT can be prolonged with this class of medications. Relatively new warning associated with these shows an increased risk of aortic dissection or rupture, so it must be avoided in these patients. And adequate hydration should be done for patients taking this medicine to prevent crystalluria. Now we'll move on to vancomycin. So this inhibits bacterial cell wall synthesis by blocking glycopeptide polymerization through binding tightly to D-alanine portion of the cell wall precursor. So with this medication, some side effects seen are red man syndrome. So red man's is not an allergic reaction, but it is a histamine-mediated response to the medication being infused too fast. So this can be overcame through slowing the infusion rate. Normally we'll double the infusion time for patients with red man syndrome. Ototoxicity and nephrotoxicity can be seen with this as well. It's important to monitor kidney function when patients are on this. Vancomycin requires monitoring through troughs. So there is a new dosing method using area under the curve in pharmacokinetics, which some institutions have moved to. There's just not enough evidence for all indications yet, so we still dose based off of troughs. It's the oxazolidinones. So linezolid binds to 50S subunit on ribosomes to inhibit protein synthesis. With this medication, serious myelosuppression can be seen, especially at greater than 14 days of therapy, but you can see it sooner. And neurologic toxicity, such as peripheral and optic neuropathy, can be seen with use greater than 28 days. So patients should not use this for long-term treatment due to these effects. So it's not recommended to do this longer than 14 days. Serotonin syndrome can occur when used with other serotonergic agents, so it's important to look out for drug interactions that may occur. So this slide is a list of antibiotics that cover MRSA. So on this, I've highlighted in bold the two that are mentioned in the guidelines, vancomycin and linezolid, but there are many others that can be used. And some of these you'll use for community-acquired MRSA and not hospital-acquired. This is a list of our anti-pseudomonal antibiotics. The bolded medications are mentioned in the guidelines. Now, we can use others just depending on what the sensitivities are, and that goes for MRSA as well. So in summary, the most common bacterial etiology is strep pneumo, followed by H. flu and M. cat. It is not recommended to use a macrolide alone. A beta-lactam plus macrolide or doxycycline can be used instead. Respiratory fluoroquinolones are an alternate first-line option for treatment. When treating CAP, the severity and risk factors for resistance will drive treatment. So, thank you for this, and our emails are here on the bottom of the slide. Feel free to contact us or find us at the hospital if you have any questions.
Thank you very much.